Welcome to the Deep Dive. Today we're tackling a really crucial topic, Fragile X syndrome. Especially relevant if you're in pediatrics or, prepping for exams like the MSRA.
Absolutely.
We've got a great set of notes here, and basically our goal is to pull out the most important high-yield bits for you.
Make it clear, make it stick.
Exactly. Think of this as your shortcut to really getting a solid handle on FXS.
Yeah, and it's important because, well, Fragile X is the most common inherited cause of intellectual disability, so you will come across it.
Right.
So yeah, we'll break down what it is, the causes, risk factors, how it affects the body.
Pathophysiology.
Exactly. What else that could be the differentials, who gets it, what it looks like clinically, how we diagnose it, what we can do management, and, the outlook, prognosis, and any complications.
All the key stuff.
Ah.
We want to keep it straightforward, focused.
Let's do.
Okay, so let's jump right in. The definition. In simple terms, what is Fragile X syndrome?
Okay, so FXS, Fragile X, it's a genetic disorder. Fundamentally, it leads to intellectual disability,
Right.
but also often behavioral challenges and some quite specific physical features. And the key thing, like I said, it's inherited, it runs in families.
And it's the most common inherited cause of ID.
That's the one to remember, yes. The root cause. It's a mutation, a change in a specific gene called FMR1.
FMR1, got it.
Yeah. And this gene, its job is to make a protein called FMRP, Fragile X mental retardation protein, that we just say FMRP.
Okay.
And this FMRP is crucial for the brain, development, function. It's really important.
Right.
So when you have this mutation in FMR1, you don't make enough FMRP, or sometimes none at all.
And that causes the problem.
Exactly. That lack of protein has knock-on effects, often associated with ADHD, autism spectrum disorder, anxiety. Those are common co-occurrences. And physically, you might see things like more prominent ears. In males, larger text become noticeable after puberty. And in females, sometimes pronounced shyness is a feature.
So it's this cluster of things all stemming from that FMR1 gene and the missing FMRP protein.
That's the core idea, yes.
Okay, so that's the what. Let's dig into the why, the etiology. What actually causes this FMR1 gene mutation?
Right. So the specific type of mutation is quite interesting. It's what we call a trinucleotide repeat expansion.
Okay, sounds technical.
Yeah, a little. But basically, inside the FMR1 gene, there's a sequence of 3 DNA letters, C, G, G, that repeats. CGG. In most people, this repeats, say, up to maybe 40 or 50 times. That's normal.
Okay.
But in Fragile X, the CGSI section expands dramatically. It repeats over and over again.
Like a stutter in the gene.
Kind of, yeah. And if that repeat number gets really big, over 200 CGG repeats, we call that a full mutation.
Over 200.
And that's what typically causes Fragile X syndrome. This massive expansion essentially shuts down the FMR1 gene. It gets silenced.
So can't make the FMRP protein.
Exactly. No protein or very little.
Right.
Now, how does it get passed down? The typical pattern is X-linked dominant.
Okay, X-linked, meaning it's on the X chromosome.
Correct. The FMR1 gene sits on the X chromosome. Remember, females have 2 X's, XX. Males have 1 X and 1 Y, XY.
Right.
Because it's on the X, it affects both sexes, but often more severely in males, as they only have that 1 X chromosome carrying the mutation. Females have a second X, which might be normal and can compensate to some extent.
That makes sense.
And it's worth noting, while it's usually inherited, sometimes this full mutation can happen spontaneously, a new mutation in the family.
Okay, so family history sounds crucial then. What are the main risk factors we should be aware of?
Family history is definitely number one. If you know there's FXS in the family, or maybe unexplained intellectual disability or premature ovarian failure in female relatives, those are potential red flags.
Right.
And female carriers are key here. A woman carrying the mutation, either a full mutation or something called a premutation, which is a smaller expansion, has a 50% chance with each pregnancy of passing that mutated X chromosome to her child, boy or girl.
50-50 chance each time.
Exactly. Now, for male carriers, it's a bit different. They only have 1 X chromosome. They will always pass this X chromosome to their daughters.
Always your daughters.
Yes. So all daughters of a male carrier will inherit the mutation, usually as a premutation. But males pass their Y chromosome to their sons.
So sons are unaffected by their father carrying it.
Correct. They don't get the father's X chromosome, so they won't inherit the FMR1 mutation from him. So, yeah. Family history, especially tracking it through the female line, is a major risk factor.
That clarifies the inheritance pattern nicely. Okay, we know the cause, the risks.
Yeah.
How does this actually mess things up in the body? The pathophysiology.
Right. Let's connect the gene to the symptoms. So that big CGG expansion, the full mutation over 200 repeats, it triggers a biological process called methylation.
Methylation.
Yeah, think of it like chemical tags getting stuck onto the gene. These tags effectively silence the FMR1 gene. They switch it off.
Like putting lock on it.
Exactly like putting a lock on it. So the gene is there, but the cell can't read the instructions to make the FMRP protein. And FMRP, as we said, is vital in the brain. Its main job is related to synapses, the connections between brain cells, neurons.
Synapses, right.
It helps regulate the production of other proteins right there at the synapse, which is critical for synaptic development and, importantly, synaptic plasticity.
Plasticity, like the brain's ability to adapt and learn.
Precisely.
Yeah.
It's how connections strengthen or weaken based on experience, essential for learning, memory, everything, really. FMRP is like a traffic controller for protein production at these crucial connection points.
Okay.
So when you don't have enough FMRP because the gene is silenced, this whole process goes haywire. Synaptic connections don't form correctly, they don't mature properly, and that plasticity is impaired.
So the brain's wiring is disrupted.
That's a good way to put it. This disruption in basic neuronal function is what underpins the intellectual disability, the developmental delays, the behavioral issues. It all tracks back to the lack of FMRP messing up those synaptic connections.
Wow, okay. That really links the genetics to the clinical picture. Now, if a child presents with some of these signs delays, maybe behavioral stuff, what else might be going on? The differential diagnosis.
Yeah, super important. You can't just jump to FXS. There's overlap with other conditions. Other genetic causes of intellectual disability are high on the list, like Down syndrome, Prader-Willi, Angelman syndrome,
Okay.
autism spectrum disorder, ASD is a big one. Lots of overlapping features. And remember, about 30% of males with FXS also have ASD.
Right, the comorbidity.
Exactly. Other chromosomal issues causing learning difficulties need consideration, like Klinefelter syndrome, and then there are other specific syndromes, Rett syndrome, Lujan-Frenz, Soto syndrome. Even Marfan's can have some overlapping connective tissue signs, though it's very different overall. And don't forget things like ADHD, which is very common in FXS, but also exists on its own, and developmental language disorders. These might be the first thing noticed.
It's got a list.
It is, which is why a really thorough assessment, looking at the whole picture, the development, the behavior, the physical signs, the family history is needed. But ultimately,
Genetic testing seals the deal.
genetic testing is what confirms or rules out FXS definitively.
Okay, so let's talk numbers. Who actually gets Fragile X? How common is it? The epidemiology.
In the UK, the figures are generally estimated around 1 in 4,000 to 5,000 for males,
Okay.
and maybe 1 in 6,000 to 8,000 for females. It's a bit harder to pin down exactly for females because the presentation can be milder.
Right, due to the two X chromosomes.
Exactly. Globally, the numbers are pretty similar. Maybe 1 in 5,000, 7,000 males, 1 in 4,000 to 6,000 females. Importantly, Fragile X affects people of all ethnic backgrounds. There's no specific predisposition there.
Good we know.
And what's really interesting and maybe more relevant day to day is the premutation, that smaller expansion of the CGG repeat between 55 and 200 repeats.
Right, the carrier state almost.
Sort of, yeah. It's much more common. Estimates vary, but maybe 1 in 130 to 260 females are premutation carriers.
Wow, that's quite high.
It is. And for males, maybe 1 in 250 to 810. These individuals don't usually have FXS themselves, but they are at risk for other conditions like FXTS, Fragile X-associated tremor ataxia syndrome, or FXPOI, Fragile X-associated primary ovarian insufficiency. And crucially, they can pass on an expanded repeat to their children.
So the premutation can expand to a full mutation in the next generation.
Especially when passed on by a female carrier, yes, the risk of expansion is higher.
Okay, so it's definitely out there, and the premutation is even more common. Now, the clinical picture. What does Fragile X actually look like? What are the signs and symptoms we should recognize? Maybe we can use that mnemonic, facelift.
Yeah, facelift, that can be helpful. Let's break it down. So F for facial features.
Right.
Often a long, narrow face, maybe a high forehead, prominent jaw, large or prominent ears. That's the E for ears, too. These might become more apparent after puberty.
Right.
Then A for anxiety. Very common. Obsessive-compulsive traits, mood swings, lability, sometimes aggression. Shyness, especially in girls, fits here, too. C for connective tissue issues. This covers things like those prominent ears again, but also hyperextendable finger joint.
Really flexible joints.
Yeah, overly flexible. Maybe flat feet, soft skin, sometimes mitral valve prolapse in the heart.
Okay, face E.
What's L?
L for large testes. Macroorchidism.
Yeah.
This is mainly seen in males after puberty, often 2 to 3 times the normal size. It's a key sign.
Right, important one. I.
I for intellectual disability. This is the core feature, usually ranging from mild to severe. Developmental delays are almost always present, hitting milestones late. IQ is typically below 70.
Okay.
F, maybe hand flapping. Or other repetitive behaviors, quite common, often overlapping with autistic features.
Okay. And T?
T for tone. Often low muscle tone, hypotonia, especially in infancy, can contribute to clumsiness.
So facelift, facial features, anxiety, connective tissue, ears, large tests, intellectual disability, hand flapping repetitive behaviors, low tone. That's helpful. It covers a lot of the key areas. Other things you might see are difficulties with eye contact, seizures, about 15% of male sleep problems, and speech and language issues like repeating words or phrases, echolalia, or getting stuck on topics, perseveration.
And diagnosis typically happens when?
Often around age 3, maybe a bit later, usually prompted by those developmental delays becoming obvious, but confirmation always comes back to
The DNA test, the FMR1 gene analysis.
exactly. Looking for that CGG repeat number. Less than 45 is normal. 55 to 200 is that premutation zone risk of expansion, risk of associated disorders, and over 200 repeats is the full mutation, highly likely to cause intellectual disability.
And you can test before birth.
Yes, prenatal testing via amniocentesis or CVS is available for carriers.
Got it. So when FXS is suspected, how is it actually investigated and confirmed?
Well, as we've said, the absolute gold standard is genetic testing, DNA analysis of the FMR1 gene.
From a blood test, usually.
Usually a blood sample, yes. Or for prenatal diagnosis, cells from chorionic villus sampling, CVS, or amniotic fluid. That test looks directly at the FMR1 gene to count the CGG repeats.
Okay.
Taking a detailed family history is also really important. It can highlight potential patterns suggestive of FXS or premutation carriers across generations.
Right. Looking for those clues.
Different lab techniques might be used. PCR polymerase chain reaction is good for picking up normal repeats and permutations. For the big full mutations, sometimes southern blotting is needed, although PCR methods are getting better at detecting these too.
Okay.
And there's also methylation testing. This checks if the gene is actually silenced, switched off, which confirms the functional impact of a full mutation.
So it checks if the lock is on.
Exactly. Sometimes, very rarely, FXS is caused by other mutations in FMR1, not the repeat expansion, like a point mutation or deletion. So if repeats are normal but suspicion is high, further molecular testing might be done.
And things like developmental assessments.
Oh, absolutely essential. Cognitive tests, behavioral evaluations, speech and language assessments. They don't diagnose FXS, but they are crucial for understanding the individual's strengths and needs and for planning management. But the diagnosis itself rests on the genetic test.
Crystal clear. Genetic testing is key. So, once confirmed, what's the management strategy? What can be done? Maybe we can use team. Therapy, education, accommodation, medication.
Team, yeah, that works well. Because it really is a team effort. Management is all about a multidisciplinary approach.
So lots of different specialists involved.
Definitely. You'll likely have geneticists, developmental pediatricians, neurologists, speech and language therapists, occupational therapists, psychologists, special education teachers, all working together with the family.
Okay, so the T for therapy.
Big focus here. Speech and language therapy is vital for communication. Occupational therapy helps with motor skills, daily living activities, and sensory processing issues. Behavioral therapy or interventions are key for managing challenging behaviors, anxiety, ADHD symptoms.
And E for education.
Absolutely crucial. Tailored educational support within the school system, often requiring an individualized education plan, IEP or equivalent, to help them learn and reach their potential.
A for accommodation.
Yeah, making adjustments in the environment, school, home, eventually workplace to support their needs, managing sensory sensitivities, providing structure, using visual aids, that kind of thing.
And M for medication.
Yes, medication doesn't treat the underlying cause, but it can be really helpful for managing specific associated symptoms.
Like the ADHD or anxiety.
Exactly. Stimulants like methylphenidate or dextroamphetamine are often used for ADHD symptoms. SSRIs, selective serotonin reuptake inhibitors, can help manage anxiety or obsessive-compulsive behaviors. Sometimes antipsychotics, like aripiprazole, might be used cautiously for severe irritability or aggression, and if seizures occur, anticonvulsants are needed.
Okay.
And underpinning all of this is genetic counseling for the family, helping them understand the condition, recurrence risks, implications for other family members, and ongoing family support.
Sounds comprehensive. What about specific drugs targeting the FMRP pathway? Has research yielded anything there?
That's been a major focus of research, trying to find drugs that could compensate for the lack of FMRP or correct the downstream signaling problems. There was a lot of hope around drugs targeting, for example, the MGLR5 receptor pathway.
Right.
But honestly, results from large clinical trials have often been disappointing. It's proven difficult. The condition is complex, individuals vary hugely,
Yeah.
measuring outcomes is hard, and maybe the animal models don't perfectly translate. Some trials with things like minocycline, lithium, memantine have shown mixed or limited results. Folate supplementation was studied early on, but again, limited conclusions. There's some preclinical buzz around metformin, but it's early days.
So still mostly supportive and symptomatic management for now.
Pretty much. The mainstay remains that comprehensive team approach: therapy, education, accommodation, and medication for specific symptoms, plus strong family support.
Okay. What about the long-term picture? The prognosis for someone with Fragile X?
The prognosis, well, it really varies depending on the individual. The severity of the intellectual disability, the behavioral challenges, any associated medical issues.
Right.
It's generally true that the cognitive and behavioral challenges are lifelong. They persist into adulthood.
Okay.
However, and this is a really crucial point to emphasize, life expectancy in Fragile X syndrome is typically normal.
That's very important. So it doesn't shorten lifespan.
Generally, no. And with early diagnosis, getting that multidisciplinary support in place, early good educational interventions, and managing any health issues, individuals with FXS can lead fulfilling lives, achieve a lot, and have a good quality of life. Early intervention makes a big difference.
That's really positive and important to hear.
Yeah.
What about prevention? Is there anything that can be done on that front?
At the moment, there aren't any national newborn screening programs for FXS, not in the UK or the US, for example.
Okay.
There was actually a review in the UK back in 2019 that decided against routine antenatal screening for the general population, citing insufficient evidence at the time.
Right.
So screening is generally targeted. It focuses on carrier identification within families where FXS is already known, or testing children who present with developmental delay or intellectual disability where FXS is suspected. It's more about informed reproductive choices for known carriers.
Understood. And finally, what sort of complications might people with Fragile X face over time?
Well, the core features themselves can be seen as complications. In a way, the ongoing developmental delays and learning difficulties obviously impact life significantly.
Sure.
The behavioral and emotional challenges, anxiety, ADHD, ASD features, aggression, can be very difficult for the individual and the family. Social and communication difficulties can affect relationships and integration. Sensory processing issues can make everyday environments challenging. There's that increased risk of seizures we mentioned, about 15% of males. And sometimes other medical comorbidities can arise, like the potential for mitral valve prolapse or other connective tissue-related issues like joint laxity or scoliosis. Ear infections can also be more common in childhood.
Okay, a range of things to be aware of and manage.
Yes, highlighting the need for ongoing monitoring and care.
Right. Well, let's wrap up this deep dive then. Fragile X syndrome. It's clearly a complex genetic condition, a lot to take in, with a wide spectrum of effects.
Definitely.
But understanding the underlying cause, the FMR1 gene and the FMRP protein, and crucially, implementing that supportive, multidisciplinary team approach, it really can make a significant positive difference.
Absolutely. Early diagnosis, tailored support, that's key to improving quality of life for individuals with FXS and their families. If you're studying this, hopefully breaking it down has helped solidify the key points. Go back through your notes, maybe test yourself.
And for all of you listening who are prepping for the MSRA, remember those pediatric stations. Don't forget pastmsra.com and freensepsra.com for loads more great revision resources.
They're fantastic resources. Thanks for joining us today as we unpacked Fragile X syndrome.
Yeah, thanks for listening. Until our next deep dive.